Good morning, everyone. Welcome to Indian Cytogastroenterology Masterclass. And this is a 19th edition of ISG Masterclass. It had been a wonderful journey to have a wonderful speakers on some of the very, very important topics which are clinically relevant. And all the talks delivered till now had been remarkably, people have appreciated very, very much on these talks. Last week, we had a talk on chronic hepatitis C treatment, and this was delivered by Dr. Pankaj Puri. We had a lot of comments and appreciation for Dr. Puri. We want to thank Dr. Puri for his wonderful talk on chronic hepatitis C. We move to yet another talk on a very common disease, that's gastroesophageal reflux disease. And we know that 10 to 15% of our population have GERD. GERD is not difficult to treat, but there are some patients where GERD becomes difficult and is hard to treat such patients. Today's focus is on difficult to treat GERD, and for that we have one of the renowned speaker, Dr. Shobna Bhatia. Dr. Shobna Bhatia had been at KM Hospital, Mumbai, and from where she super innovated. Now she is at HN Reliance Hospital in Mumbai as a head of neurogastroenterology and mortality in Mumbai. She had been the treasurer of ISC. She had been the coordinator of Indian Cytogastroenterology Task Force on GERD. And over last 10 years, done remarkable work on GERD on behalf of ISG. First, she led the data collection from all over the country, and the data was published in our journal, followed by guidelines on GERD, which are published about 2 years back. And then as a part of initiative taken by API and ISG to make guidelines of physician. And she also led that guideline process and drafted the guidelines, which is under publication with JAPI, which is a journal of Association of Physicians of India. Well, her contribution in GERD has been remarkable, and for this talk, we can't have any person better than Dr. Bhatia. Welcome, Dr. Bhatia, for this masterclass, and we look forward to listen to you on this topic. And to moderate this session, again, we have a very renowned person, Dr. Thomas Verghese. Thomas Verghese had been head of gastroenterology at Calicut Medical College in Calicut, and now after superannuation, he has joined Malabar Medical College, Calicut. He had been a great teacher, and we welcome Dr. Verghese Thomas for moderating this session. Over to you, Dr. Saraswat, for a formal opening of this lecture.
Thank you, Govind. Good morning to all the participants and the viewers from the various states of our country and from our neighboring countries. As Dr. Govind has mentioned, in this 19th edition of the ISG Masterclass, we look forward to the continued participation of all the ISG members, the DNB, DM residents, as well as gastroenterologists, and particularly for this session, even the general physicians who commonly handle the problem that we'll be discussing today. As Dr. Govind has mentioned, reflux is probably one of the most common GI ailments which is present worldwide. That you just have to take some antacid, some tablets for suppression of acid, and you are fine. However, GERD is not that straightforward, and there are situations where despite best treatment, despite documentation, patient of the reflux, the patient does not respond, and it is these difficult to treat patients who will be discussed in detail. Their management will be discussed in detail today. And it's a great pleasure to welcome Dr. Shobna Bhatia as the speaker on this session. Dr. Govind has already mentioned the accolades and the achievements that she has had. Not to mention that she has been the editor of the Indian Journal of Gastroenterology earlier. And my connection with Shobna goes back, I think, about 30 odd years, and probably more. And it's to do with our association with Professor S.R. Naik. She worked with Dr. S.R. Naik at the KEM hospital, which she eventually went on to head the department until he moved over to Lucknow and opened the gastroenterology department here. And in those early years in the 90s, we had Shobna as a regular visitor to our department. And our shared interest in reflux and GI motility has developed ever since. She has a deep understanding of the topic. She has also a knack of explaining complicated things in a very simple manner so that people can understand and retain the important messages related to the topic. With these few words, I would request Shobna to please begin her talk this afternoon.
Thank you, Vivek, for that personal piece of introduction. Yes, I do remember the first time that I came to SDPGI was during my exams, my DNB exams, and you were the moderator, you and Gordas. And in the evening, when I couldn't find some good food, I remember Vivek called me home, and I had some lovely dinner with him. So that's how long back we go. When was that? That was in 1990. That's like 30 years ago. In May were my exams, and yes, exactly 30 years ago, Vivek. Unfortunately, now we can't travel as often, but I'm sure we can see each other on the screen and still interact. So good afternoon, everybody, and welcome to this ISG session. In the last few weeks, we've been invited to so many webinars, but the webinars I've enjoyed most are the ISG lectures. The rest of them are just getting too much. So what I'm going to do is I'm going to start sharing my screen, and the topic that I have for the day is GERD that does not respond to PPIs. In the middle of the session, I think we will have a small break for questions. So people who want to ask questions, please start giving them on the chat box that you can see, and we'll see how to go about them. So the first thing is we'll start with a case which almost everybody sees this kind of a case. A 30 or a 40 or a 50-year-old person comes with heartburn for almost 4 years, intermittent regurgitation, and has taken PPI for the last 3 years but has not responded well. He still says that he gets reflux symptoms intermittently. Now, since the last 1 month, somebody's given him a double dose PPI, and it hasn't made much of a difference. Importantly, this patient did not have dysphagia, and that's a question that you always should ask in a patient who's got reflux. So we come to non-responsive GERD, and this generally means that there are persistent symptoms despite a double dose PPI for 1 or 2 months. There are some definitions which say 8 weeks double dose PPI. Some people say you can take it for 12 weeks and decide. But remember one thing, that when you step up from single dose PPI to double dose PPI, in a patient where you are not sure that the patient has reflux, the gain in symptoms, the gain in relief is only about 10 to 15%. So many patients will actually not respond to this double dose PPI. So technically, we are looking at two situations. The first situation is where the patient has symptoms which are not improving. That means the patient has heartburn which is not improving. And here, again, I said, like some people will say that it's 12 weeks. Some people will say it is 6 to 8 weeks. But yes, the patient is not responding. And here, we don't know that the patient really had reflux. The implication is that the symptoms may not be from reflux. The second situation is a true refractory GERD, which means you have proven that this patient had reflux. In whatever way you're sure that this patient had reflux, the patient is still not responding to a 12-week course of double dose PPI. And here the implication is that your management of reflux has to be improved. And therefore, the management of the second situation is probably easier than the first one, where you're not even sure that the patient has reflux. So let's see why patients do not respond. The first is compliance. And then there are many other disorders which we'll come to. Therapy related may be resistance to a PPI, or once that H. pylori is eradicated, the patient may not respond well. Coming to the most important factor why patients do not respond, and that is compliance and dosing. PPI, as we know, have to be given on an empty stomach. If they're not given on an empty stomach, they're not likely to be absorbed, or that their action may come up when the acid secretion peak has already gone away. In that case, the PPIs are not going to act. They do not interact with antacids, and they do not have any dose adjustment for renal or hepatic failure, and even in the elderly. But in children, you require the same dose that is required for adults. For example, in adults, you require less than 1 milligram per kg. It's actually 0.6 or 0.06 milligram per kg, whereas in children, you require 2 to 6 milligrams per kg. And in children, if you give them a pediatric dose, as we would say, give half a tablet, the children are not going to be responding. Another thing is about compliance. Most patients, if they're feeling better, they're going to cut down their dose and start thinking that if they're better now, they don't need to take their drug. And only 30 to 50% of patients, despite having severe symptoms at the onset, will continue treatment at 6 months. And then later on, they may say that they're not feeling better even after they start the treatment, probably because the expectation from treatment has gone higher. They want to be absolutely asymptomatic, but PPIs are not going to make them completely asymptomatic. So this is a graph which I need to explain a little. Depending on what is the situation in a patient, what is the kind of therapeutic gain that you will expect. So remember that PPIs are very good drugs, but they are not good for everyone. They may not be as good for esophagitis as they are for heartburn symptoms. This graph was created by Peter Carolus from Chicago. He's one of the real innovators in reflux disease. And here it comes that in patients with esophagitis, if you give them a placebo, the esophagitis isn't going to heal well. But with PPIs, the esophagitis will heal in about 70 to 80% of patients. In mild esophagitis, even if you give a placebo, about 20% of cases, the healing will occur and the therapeutic gain is much higher. However, if you look at heartburn relief, which means that the patient had esophagitis and you gave them PPIs, the esophagitis went away, but the relief in heartburn is only about 60%. About 40% of patients will still say that they continue to have mild symptoms, even though the esophagitis has healed. In contrast, if you take patients with non-erosive reflux disease, the gain is even lower with PPIs. If you take patients with regurgitation, the acid symptom will go away. That means the regurgitation will now become a bland regurgitation. But because these patients generally have volume reflux associated with maybe a hiatal hernia, the symptom relief is much lower. When you take patients with non-cardiac chest pain, in most cases, when a patient has chest pain and the cardiac workup is negative, even before the patient comes to a gastroenterologist, the cardiologist would have already put the patient on a PPI. In these patients, if you have proven that the pH studies were positive, you get a good therapeutic gain with PPIs. However, if the patient's GERD was negative, proven negative, in that case, there's not much of a gain with PPIs. And the same thing holds for chronic cough and hoarseness, where even if there is a pH positivity, the therapeutic gain with the PPI is really not much. And this is something we all have to remember, that PPIs are good drugs for healing, but for symptom relief, you need additional stuff. Yes. Okay. So one of the reasons for incomplete response to PPI maybe that standard PPI therapy is not giving you ideal symptom resolution. And as I said, even with healed esophagitis, about 30% continue to experience symptoms. Now, this patient has not responded. What should we do? So in a classic case, if the patient comes on visit 1, patient has classic symptoms of heartburn and or regurgitation, all of us would say, okay, let's give him a PPI for 4 weeks and let's see what happens. On visit 2, if the patient has not responded, you do an endoscopy. Now, once you've given the patient a month or 2 of PPI, if you do an endoscopy at this stage, more than 80% of your patients are going to have a normal endoscopy. Probably some patients who had mild esophagitis would have already healed by now. And I'll just go ahead and show you all the grades of esophagitis. These esophagitis grades were developed a few years ago, validated as grade A, B, C, and D. Grade A, you see mild esophageal erosions on the folds, not really circumferential. And in grade C and D, you start seeing severe esophagitis. It's recently been found that even amongst normals who do not have much symptoms, grade A esophagitis-like picture may be seen. And therefore, the specificity of grade A esophagitis is really very low. And therefore, it's only if patients have grade B or higher esophagitis that you say that definitely these patients have esophagitis. The other thing that an endoscopy can tell you is whether there are any confounding other diagnoses. And the most common one that is being discussed in the West is eosinophilic esophagitis. It's not as common here, and there's one paper that's come from Vineet and Govind, where they found that amongst patients who did not respond to a PPI, about 2% of patients had eosinophilic esophagitis on biopsy. Many of these patients will have a background of allergies, like they would have atopies like asthma or skin allergies. Maybe the eosinophil counts will be high in the peripheral smear, but in about 60%, the peripheral smear will be normal. In some patients, you might find candida or other diagnosis, or even a hiatal hernia. But hiatal hernia on its own is not sufficient to say that this patient has gastroesophageal reflux. At this point, it's important to take a good history. And if you, review the good history, especially if the patient has had mild dysphagia, food impaction, and allergies, you think of eosinophilic esophagitis. There are some patients who keep on having regurgitation, which is really bland and it is not sour. And when this happens, it is possible that they have a stricture, they don't have reflux, and therefore you keep on treating them with a PPI, but nothing happens. Secondly, if the patient has not responded, it's always good to take a biopsy and see whether there are any abnormalities, mainly eosinophils. Now, in this patient, the endoscopy was normal on 2 occasions. And if it's been done by someone you trust and someone whose findings are usually good, then in that case, there's no point in repeating an endoscopy at this time unless you want to take a biopsy. So again, we'll talk about non-responsive GERD here. As we said, it's refractory GERD symptoms. Their symptoms may not be from reflux. The patient's endoscopy is normal. True refractory GERD, symptoms caused by reflux, and this is where symptoms are from inadequate management of reflux. We can take a break here, Dr. Saraswat.
Yeah, so we can have a brief break here because I don't think we have got maybe some questions Professor Varghese could address. We are just about 20 minutes into the talk. Okay.
I think at 20 minutes, I thought we would have questions, So that's the reason I.
Dr. Varghese, if you have some questions that you could put to Dr. Shobna.
Yeah, I have a lot of questions. Already many questions are here. Can I ask the questions straight away?
Yes, please.
Okay, now Dr. Anand Chennai has asked about acid pockets. Yeah. Does acid pockets in presence of hiatus hernia have a DT role in refractory GRD? I think you are going to talk about hiatus hernia later. Maybe.
Yes, I will be talking about acid pocket and hiatal hernia.
Okay, yes. Dr. Bhavesh Bhatt from Lucknow has asked, when to consider double dose PPA? After how many months of single dose PPA?
1 month or maybe even 2 months.
Okay, Dr. Anand again asked about LPR.
GRD, yes.
Laryngopharyngeal reflux, can it be part of GRD and how to differentiate? Maybe you are going to talk about it later.
No, I'm not going to be discussing the extraesophageal manifestations because that's not going to be part of this.
Okay.
It's very difficult to take that. Yes.
Okay. Pradeep Nigam from Reva. What's the cutoff age before which PPA should not be given?
There is no cutoff age. I have given it even in 1 and 2 month olds.
Okay. Anand from Chennai has again asked a question. pH monitoring for response to PPA therapy, should it be run routinely?
We are coming to that.
Later.
No, there is no. See, if a patient is, so something which is very clear. If a patient is responding to your PPI and you want to send him for surgery, that is the only time you will do a pH metry.
Okay.
Now, if a patient not responding is where pH metry has a bigger value.
PPA in pregnancy and refractory cases, is it safe?
So far, there haven't been any cases of problems in pregnant women, and they are being used. Though, from what I know, lansoprazole is the only one that's approved for pregnancy, and also for children. Lansoprazole is the one that's available in smaller tablets and syrups.
Sunil Raviraj from Trivandrum. Is it mandatory to do 24-hour pH monitoring in all patients to prove GRD?
They're coming to that.
Okay.
We'll be coming to investigations. So anything that's related to endoscopy and symptoms we can take now.
Okay. Then someone has asked, I think Dr. Madan from Hyderabad, do you have any preference over any particular PPA or others?
So there are a lot of studies on the types of PPI and finding out whether one is better than the other. And there was a huge meta-analysis which was actually overpowered, which showed that esomeprazole had the best response. But in a given patient, in a routine case, at the end of 1 week, all PPIs are almost equal.
Okay. Dr. Shivaprasad from Vishakhapatnam, considering the overlap of eosinophilic esophagitis and GERD as a condition associated with eosinophilia, when is it necessary to take an esophageal biopsy?
So this distinction between EOE, which is responsive to PPI and not responsive to PPI, was taken away last year. Originally, we used to say that if a patient, you want to show that the patient has eosinophilia, you just take biopsies only after 4 weeks of taking the PPI, only then can you do biopsies. But this distinction has been taken away. And in patients who have atopy, and even if the patient has a normal looking mucosa and you've taken biopsies and you show eosinophilia, you try PPI. If they don't respond, you directly put them onto locally acting steroids.
Dr. Venkatakrishnan from Coimbatore. In lymphocytic esophagitis is also included as a condition causing unresponsive GRD. Your opinion?
It is possible, but usually lymphocytic esophagitis will have some degree of odynophagia or dysphagia. And these patients don't have such long-standing symptoms.
Dr. Jadwani,
come back again, sir?
Okay, fine. We'll continue with the talk of Professor Bhatia. Over to Professor Bhatia.
Okay. So I'll just start sharing my screen again. So at this point where a patient has not responded, we have two questions. As I said, there are two types of patients. Ones in whom the reflux is there, but the patient is not responding, and in some where there is really no reflux, and your investigations are going to be based on this. So if you look at literature, the number of tests that have been described are enormous. Symptoms GERD questionnaires have also been tried, a good sensitivity, good specificity, but again, whether you use the questionnaires or not, the sensitivity and specificity of symptoms is the same. Endoscopy we already talked about. If the patient has an abnormal endoscopy, that means there is grade C or grade D esophagitis, there is a stricture, there is a Barrett's esophagus, you are absolutely sure that this patient has reflux. If the patient has just grade A esophagitis, mild changes on NBI, you are not sure whether this patient really had reflux. It's also possible that the PPI that you gave the patient treated the reflux. Biopsy we discussed. The one test that is still done by some people is a barium swallow. We don't recommend it as a diagnostic test for reflux, but it is good when you're suspecting a hiatal hernia, whether there is a stricture, it can be seen in that, but reflux cannot be diagnosed by this. The other test that is done is salivary pH metry, which is one of the tests that is recommended by some people. It is a good test, but still the specificity and sensitivity haven't been proven. So I'm going to spend a little amount of time talking about ambulatory reflux monitoring, and maybe I'll give a little detail about that. So our next investigation is going to be pH metry. Unfortunately, pH metry can be done without manometry, but usually you need to place the pH catheter, the probe, 5 centimeters above the LES. And in order to find out where the LES is, you've got to do a manometry before. So manometry does not diagnose reflux. There are some new parameters within manometry which have been shown to suggest reflux, but it is not specific for the diagnosis of reflux. The additional reason that you do a manometry is to find out whether there is any other diagnosis. So let's take this manometry here. This is on the left, a normal manometry, where you see that on the top, that dark red band is the upper esophageal sphincter. In the lower, the green band is the lower esophageal sphincter. As you give a swallow, there is a progression of peristalsis that you can see in these reds. Whereas on this right side, you see that there is absolutely no peristalsis. If you compare it with the left and you look at the right, you see that the lower esophageal sphincter, which is at the bottom, is not opening at all at a swallow. This is a diagnosis of achalasia. And this is what achalasia will look like. This is something that you can find maybe in 2 or 3% of patients who have come with only heartburn. Most of these patients will not complain of predominant dysphagia, but if you probe them, they may say that they had mild dysphagia intermittently. So this is a couple of studies done in the last 5 years, looking at the outcome of manometry in patients who do not respond to gastroesophageal reflux symptoms. About 2 to 3% of patients will have achalasia or sometimes a distal esophageal spasm, but these patients usually will have chest pain. Very few patients will have a jackhammer, but there are a lot of patients who will have absent contractility, what we call as esophageal dysmotility or fragmented peristalsis. And these minor motility disorders are more often seen in patients who have reflux symptoms rather than the major motility disorders. However, before you send a patient for surgery, it's important that a manometry be done and things like achalasia get ruled out completely so that patients do not have worsening of their symptoms at the end of the fundoplication. In this patient, there was a hiatal hernia, And as you can see, there are two high pressure zones, one which is the actual LES and the second which is the diaphragm below. So this is something that can be diagnosed much better on a manometry than with an endoscopy, because during endoscopy, patients may be retching and the differentiation between the LES and the diaphragmatic pinch may actually not be visible well. Once in a while, you can get mimickers of GER. Now, this is a technique which is not this is an addition of impedance in high resolution manometry, where the manometry catheter also has impedance ports. And this pink, it tells you, this pink color is the flow of liquid up and down. This is called high resolution impedance manometry. On the left side, what you see is a transient LES sphincter which, relaxation, where there is inhibition of the crural diaphragm for more than 10 seconds. And the fluid which was, as you see, from the stomach is now moving up into the esophagus and staying in the esophagus even after the esophageal contraction is over. This means that the patient is unable to clear the bolus from his esophagus, and this may be a reason why the patient is having reflux. On the second side is something more interesting. You see a person with rumination. This is a rumination episode where there is rise in intragastric pressure. The patient is squeezing the abdomen. Therefore, there is a retrograde flow of gastric contents into the esophagus. The patient swallows. Again, there is regurgitant flow. He swallows again, and again there is regurgitant flow. And intermittently, there is relaxation of the upper esophageal sphincter, because there is also the patient is taking the material into his mouth and swallowing it again. And this can often be diagnosed as reflux. But the treatment is obviously not a fundoplication in this case. This is a classical example of a supragastric belch, where you can see at the bottom end of the slide, you see that the patient is actually contracting the abdomen, relaxing the esophagus, and the esophagus relaxes, and in order to belch out the air, which you can see in black, there is retrograde movement of the air. The upper esophageal sphincter opens and lets out the air. So instead of seeing a forward movement of a peristalsis, you're seeing a retrograde movement where the upper esophageal sphincter actually opens after the air has reached there. This is classical of a supragastric belch.
Ma'am, can you use cursor, please?
Okay. I'll just try. I'll have to go back to stop sharing my slides.
No. Not that cursor for the, while explaining such kind of manometry tracings,
Yes.
hidden cursors.
Okay. No, it's not happening on Zoom.
Doesn't.
But I think, let it be. I mean,
Yes, ma'am.
I need to understand, but then this is what is one of the problems. Something else has happened here. So, okay, I think because I'm screen sharing, some things are not happening. Maybe I'll learn that next time. Okay, sorry. So what are the findings actually suggestive of GER? One is that the LES pressure may be low. Usual LES pressures are between 11 and 30 millimeters of mercury. In patients with severe GERD, they may fall to less than 10. This tells us that these patients may require long-term PPI therapy. And if the LES pressure is really very low, that is, it's defined as less than 6, these patients may require surgery. Hiatal hernia, of course, we discussed, and dysmotility, if it's more than 50% of weak or failed peristalsis, these are patients who really have dysmotility. And when we send them for surgery, it is possible that they may develop dysphagia after the surgery is over. And therefore, we've got to give them loose wraps rather than tight wraps. So what is the next investigation here? We talked about ambulatory pH metry, which was to be done, but we did manometry because we wanted to do pH metry. So here the pH probe, as you can see, has been placed 5 centimeters above the LES, and pH metry can be of two types. One is the catheter type, and the other type is the Bravo. The Bravo pH capsule is placed by endoscopy 5 centimeters above the LES. Advantage, you don't need to do manometry before that, but the disadvantage is that you need to do an additional endoscopy. Another advantage of Bravo is that you can record for up to 96 hours and you can see the day-to-day variation that can be there. In patients where a non-acid reflux is suspected, I'm coming to that, you need to also do an impedance pH metry. So when you do a pH metry for 24 hours, at this point the patient is asked to press the buttons and tell whether the patient gets heartburn or not. So the values that we look at is an acid exposure time of more than 6% is definitely abnormal. Less than that, we are not sure whether the patient actually had reflux or not. I'll be coming to these details shortly. So this is only a snapshot. When we do a pH metry, we look at number of reflux episodes, number of episodes longer than 5 minutes, maximum reflux duration, and total percentage of time when the pH remains 4 for the total monitoring. So if it is greater than 14.2, that is the Demister score, it is definitely abnormal. If it is more than 100, it is severe GERD. So this is what a pH metry graph will look like, where you see that whenever there is a pH which falls to less than 4, there is a dip in that graph. And one of the issues with pH metry is that during postprandial time, when the person has eaten, there's excess acid in the stomach. There are a lot of TLESR, some degree of reflux is bound to occur. We may have to delete these episodes because postprandial time is something that is that may give false values. And postprandial reflux is a normal phenomenon. The second thing that may happen is there is non-acid reflux, which means that the patient may be bringing out just fluid. And because after a meal, the gastric juice has been neutralized by proteins in the food, the content that is coming up is not acid and does not have a pH less than 4. The third issue is day-to-day variation. And that is what we deal with when we talk about Bravo pH metry. Some patients say that they have intermittent symptoms. So one day they have symptoms, the second day they don't. And in that case, longer durations of monitoring may be useful. When the patient is on a PPI, you may not see this pH dropping to less than 4 because of non-acid reflux or a weakly acid reflux. So this is the Bravo pH, which is placed, and the patient has to just carry it with him, just like the Holter monitor or it's a tubeless telemetry capsule. Better patient tolerability, less restriction in daily activity, because when patients are wearing a catheter in the nose, they're not very happy carrying that and moving around in the community. So this, we know that pH metry or wireless pH monitoring is extremely safe, doesn't have much side effects, but technical failures, that means the capsule coming off the esophagus and getting into the stomach and monitoring only gastric pH is something that has been shown, but otherwise it's a fairly safe and effective procedure. Now in patients where the pH metry is normal, but the patient still has symptoms, it is likely that the patient does not bring out acid, but it brings out non-acid material. And to see the flow of material, what we have to look at is the impedance. This is the kind of catheter that is there, where besides the pH probe, which is there at 5 centimeters above the LES, there are 6 impedance channels. And this testing is done only and only if the patient is proven to have GERD, which means that the patient had esophagitis, but is not responding to a PPI. So we would not do impedance pH monitoring if a patient was not responding, had a normal pH, had a normal endoscopy. Then in that case, we would do a plain pH monitoring of PPI. Here the patient will be on a PPI and we have to see what is happening to the flow of contents within the esophagus. So just a few slides on how impedance works. Now impedance tells us about the flow. So whenever the bolus is crossing the rings, we will start seeing either a decrease in impedance or an increase in impedance. So this is the bolus which enters. So normally the impedance of the esophagus is at a particular value. Whenever there is air in the esophagus or when you swallow air, the impedance will actually go up because there is more resistance. There are less number of ions in the air and therefore the impedance will go up. When there are more ions, for example, food or saline, then in that case the impedance will come down. And when this crosses the rings, you see a drop in impedance. As the bolus leaves those impedance rings, you will start seeing that the impedance comes back to normal. So this is what we call as impedance, the bolus entry and exit. And when you want to compare what's happening to the food and the contraction, the dark blue is the contraction. So the contraction always follows the bolus and there is always air in front of the bolus. So eventually what you'll end up seeing is first there is an increase in the impedance because of air and there is a decrease in impedance because of the bolus. And as the bolus exits, that is when you start seeing the pressure wave of the manometry. This can be very well seen when you're doing an impedance manometry. But when you're doing plain pH impedance, this peristalsis is not seen. But in fact, you will be able to see sometimes a pressure wave coming down. So this is what air is. This is the bolus. This is the pressure contraction. And there is an increase in impedance and we come back to the baseline signal. So this is how you will be able to see it in a continuous graph. Now, when you see this, once the tracing has been taken for 24 hours, you see that whenever there is bolus entry and exit, it ultimately forms a pyramid-like shape. That means when there is reflux, the impedance starts going up, the fluid is going up and then coming down. So therefore, it creates this pyramid-like shape. But what you actually have to look at is the last section, which shows a slight pink. I don't know whether that can be appreciated, Govind. I agree, I should have had the pointer. Let me try getting that pointer if I can. Okay.
Just try with your screen cursor.
That's what I'm trying. That's what I'm trying with the mouse. Okay, can you see it? No, you can't see mine. So I'm trying that.
Ma'am, you can go back to the keynote menu.
Yes.
And there is a option preference.
Yes. Oh, good. I'm learning that now. Yes. And
did that open, ma'am?
Yes, I got it. Slideshow.
Yes, ma'am. On the slideshow, you might be having an option. Yes.
Got it. Okay. We start seeing again. Yeah. So sorry about that. And here. So can you see the mouse now? What I'll do is I'll just go back to the previous slide so that this is understood. Okay. So as the bolus comes in, the impedance increases. Then the bolus is here. The impedance increases because there's air in front of the bolus. Then the impedance decreases because the bolus contains ions. And therefore here we usually don't use distilled water. We always use saline or you use a solid bolus. So the bolus comes down, the impedance comes down, and then the impedance recovers, and that is when the pressure flow peristalsis is seen. So this is an acid, this is a regurgitation. So you see that the bolus is coming up where the impedance is decreasing. Can you see this? So the impedance is decreasing here, the impedance is decreasing here, impedance is decreasing here. So this tells us that this is a retrograde flow where the impedance stops decreasing here and then it starts coming back to normal. So this is normal, this is normal. And how do we know that this is an acid reflux? Because the pH channel here is showing us that the pH has dropped to less than 4. This line is pH 4, and you see this pink thing which is telling us that the pH is less than 4. So this tells us that this is an acid reflux episode. Now coming to this one, this is similar. That means there is a regurgitation. The flow is coming, the bolus is returning here, this is the bolus here, but the pH has not dropped at all to less than 4, and therefore this is a non-acid reflux episode. So the impedance patterns are of two types. One where there is reverse, like this, which we call as a reflux or a regurgitation, and this is a peristaltic wave, because we see that the impedance changes are temporally from above going down below. So impedance values, if you have more than 80 reflux episodes, it is definitely abnormal, whether they are acid, non-acid, or weakly acid. Less than 40 impedance episodes in a day are considered as normal. They may be liquid, they may be gas. Now, based on these episodes, we can actually have indices. Now, whenever the patient has an episode of reflux and he has a symptom, you say that the symptom index is positive. So when the patient has the box in front of him, he presses the box or presses the cursor saying that he developed a symptom, or he writes it down. Now here, we divide the number of symptoms associated with a pH less than 4 by the total number of reflux episode and multiply them by 100. What you get is a 2-by-2 table. So if the patient has a pH change, yes or no, symptom change, yes or no, and you have a 2-by-2 beautiful table. I'll come to that in a minute. So baseline impedance is the other thing that's been talked about. And the other one is a post-reflux swallow-induced peristaltic wave, which has been propagated by an Italian group led by Edvardo Savarino. And they say that whenever there is a reflux episode, there will be a peristalsis after it. And that tells us whether the patient has a good peristaltic reserve. Now, baseline impedance is something you measure at night. Low baseline impedance is associated with an increased episode exposure to acid, and therefore it's one of the things that can be calculated when the patient does not have too many episodes on that given day. So this is what the baseline impedance will look like. It will be almost a flat graph, and this can be averaged at a time when there is no swallowing at night or the patient has not taken anything. So the cutoff value for this is less than 2,292, very weird value. But at this value, it distinguishes PPI non-responders from those who respond to a PPI. The other one that I talked about is a post-reflux swallow-induced peristaltic wave. Now, this generally indicates that the person is able to clear the acid from the esophagus, and this is what it would look like. So this is an episode of reflux where the pH has dropped here. These graphs are not very clear because I picked them up from their publications. And at the end of this, you find that there is an episode where there is a temporally forward moving decrease in impedance, which means that there was a swallow. And therefore, this is a swallow after a pH episode. And this tells us that the patient had a positive swallow-induced peristaltic wave or a reflux swallow-induced peristaltic wave, which tells us that the patient has good motility and has good reserve and can clear his esophagus after an esophageal, after an episode of reflux. This is something similar from one of our patients. So we come to now two definitions, which are reflux hypersensitivity and a functional heartburn. So reflux hypersensitivity is one where your pH was normal on impedance, but the patient had reflux episodes which were positive for, sorry, I haven't put that. But the patient had a positive symptom association. This means that if the patient had symptoms and at that time also the patient had acid episodes, it means that the patient had a positive symptom association, and more than 50 of this value suggest that this patient has reflux hypersensitivity. Reflux hypersensitivity is one of the manifestations of reflux and should be treated like reflux, not as if a person has non-reflux. On the other hand, there is functional heartburn, where the impedance pHmetry is negative. The patient has pressed that symptom button maybe 10 times, but in none of those 10 times did the patient have any reflux. So first thing for both these parameters is that the impedance pHmetry has to be completely normal. And if it is abnormal, then we don't look at these parameters. So if it is normal and you find that the patient had symptoms which correlated with the pHmetry, in that case you say that the SAP was positive, otherwise the SAP is negative, and that would be called as a functional heartburn. So if a patient had an abnormal pH or impedance test, we would first optimize acid suppression, maybe give mucosal agents like alginates, and try to decrease the TLESRs. One of the drugs that has been tried is baclofen, but because of its side effects, it's not been found to be as useful as we would expect. The TLESRs decrease, but the side effects are definitely there. The other thing is if patients have a volume reflux, that means the acid has been controlled by the PPI, but the patient continues to have reflux. In that case, it's possible that the patient had a hiatal hernia or an acid pocket, which might decrease with the Gaviscon, or the patient may have delayed gastric emptying. And this is an important test to do when patients are continuing to have regurgitation in spite of a good PPI and the acid control. So people have tried prokinetics. Unfortunately, PPIs have no effect on the esophagus or the lower esophageal sphincter. The only true prokinetic which had some effect on the esophagus was betanicol. But betanicol is no longer used for esophageal symptoms because there is side effects. Sorry. The other things that can be used are mainly for gastric emptying. They are not useful for esophageal work. And therefore, if a patient does not have any gastric emptying disorders, giving prokinetics does not really improve symptoms. If the patient has abnormalities in fundic relaxation or accommodation, that is, the patient has early satiety, In that case, levosulfide or ecoshamide may be tried, but for pure reflux, these are not useful. If the patient has a large hiatal hernia, there's predominant volume reflux, and gastric emptying tests are normal, then the patient may deserve a surgery. Now coming to reflux hypersensitivity, there's normal pH, SAP is positive, optimized acid suppression. Acid suppression, though we say that our PPIs control more than 80% of the acid, there are better acid suppressions that are now available, and one of them is now vonoprazan. Vonoprazan has been approved in, it's a Japanese drug which has been found to give almost 100% acid suppression. Of course, using it in all patients indiscriminately is going to give rise to problems. But in some patients who are really not responding, vonoprazan may be one option. The other drug, dexlansoprazole, has good relief of symptoms, especially for nocturnal GERD, but otherwise it is equal to the other PPIs. For TSR reduction, baclofen has been tried. We can also try pain modulators, and like you come here, where the patient has absolutely no reflux but continues to have heartburn. Tricyclic antidepressants have been tried, the SSRIs have been tried, the SNRIs have been tried. Let the patient be evaluated by a psychiatrist if the single drug of a pain modulator does not work. So in managing esophageal pain and refractory heartburn, first, ensure appropriate diagnosis and management and exclude a confounding diagnosis. And this, if there has to be one message that I want to give from this talk, it is this first line, that in a patient of reflux who does not respond, exclude a confounding diagnosis before pushing PPIs and doubling PPIs, switching PPIs over the years. So hiatal hernias will give rise to volume refluxes. Take a good history. Endoscopy and manometry are adjunctive tests, and eliminate noxious triggers. Can give a therapeutic PPI trial, do a pH monitoring. If pH monitoring of a PPI is to be done in patients where you are not sure that it is reflux, whereas if a patient is sure of having reflux but not responding, then do a trial on PPI and do an impedance. Plain pH monitoring will not work here. So I'll skip this. And neuromodulators for symptoms for anxiety or depression, we can try for depression, escitalopram or a TCA. And this is the final one. Normal mucosal view, rule out a primary motility disorder, normal motility, look for acid exposure time, hypersensitive esophagus or a functional heartburn. And if there is esophagitis or Barrett's, further investigations are not required. But if the patient has to go for surgery, then in that case, it is mandatory to do a PPI, do a manometry or a pH metry. And this is one thing, that patients with refractory symptoms who do not respond, almost 30 to 40% of them will not have GERD and will unnecessarily be treating. So if the patient has heartburn and sour regurgitation, important. If reflux is yes, acid or non-acid, reflux is no. It's really something else, and treat accordingly. Thank you. So I have two questions, and Govind, can the students answer these questions?
Everybody can answer them. Everybody would like to answer this question.
So you like to tell them how to answer them and how you will record?
Yes. So as you read questions, the question will pop up, the answer box will pop up on their screen. So if you can read question and tell us the question.
Okay. In a patient with reflux not responding to PPI, endoscopy shows a 2 centimeter hiatus hernia and no esophagitis. Your first option is add a local agent like alginate. Second, because there is a hiatal hernia which is refractory to PPI, send the patient for surgery. Third, do a transnasal impedance pH on PPI therapy or a pH test of PPI therapy. Can they answer?
Absolutely, ma'am. So you can answer 1, 2, 3, 4. Maybe take up a question before we will wait
Yes.
for the answer. Dr. Saraswat, want to ask one question? And
Saraswat has been taking a lot of notes, I can see that.
Well, you've got about 120 questions that have come your way already, Shobna. So,
120, I'm going to be here the whole day.
yes.
I'm coming to Lucknow for lunch.
A quick question from Dr. Sunil Raviraj in Trivandrum.
Yes.
How reliable is the Demister score to define severity of reflux?
In the more severe cases, it is reliable. In borderline cases, you know, when it is 15 to 20, that is when the specificity is not that great.
Right. So in severe cases, useful.
Yes.
Related to this is a question from Dr. Karthik in Chennai, who says that in the Lyon consensus on the impedance pH-metry, there is no mention of the Demister score.
Yes.
So why is it that it is underused in impedance pH-metry?
So Demister score is essentially based and tried only in patients who are off PPI. And the Lyon consensus is actually more towards patients who are not responding. So patients who are off PPI, you're doing a pH, they have increased the cutoff to 6% rather than the 4%. So when it was 4%, it was very useful to have the Demister score. When it has increased to 6%, the specificity of pH metry has gone up. And when specificity is gone up, then scores like Demister scores may not be that useful. That is why it's been removed from the Lyon consensus. So it's useful still in that 4 to 6%, where you're not sure whether there is reflux, you try and calculate the Demister score.
so now we have a response to the question you asked.
Yes.
42% says transnasal impedance pH, and
Okay.
almost 23% says your last choice, pH test of PPI.
Yes.
And 16% or 70% each, your first two options of adding alginate or your second choice.
Okay, so just let me, if you read this question properly, there's only a 2 centimeter hiatal hernia. Hiatal hernias are significant and create an acid pocket when they're usually more than 3 centimeters. And 2 centimeter hiatus hernia can even appear when you're doing an endoscopy and the patient is retching away. So therefore, in this patient is actually the endoscopy is normal. There's no esophagitis. So you would not send them for surgery unless you are sure that this is reflux. 2, the patient has not responded to a PPI. You are not sure that this patient has reflux. So the correct answer is a pH test of PPI therapy. Do you agree, Govind?
Yes, ma'am. Yes, ma'am.
Okay, Vivek, any thoughts? And Dr. Varghese, any thoughts?
No, I guess.
I perfectly agree with you.
Yeah.
Okay.
But I have a feeling that there's an overdiagnosis of hiatus hernia on endoscopy.
Yes.
And it's like given a complementary finding. And this adds to the confusion. The moment you find hiatus hernia, someone will say you have to go for surgery. And
Yes.
there's a conflict between physician and surgeon and some problems. Can you highlight upon that aspect? When to refer somebody for surgery?
So one is that whenever there is a hiatal hernia, if the patient has volume reflux, the patient cannot even lie down, and you've tried everything, and you proved reflux. That means there is a pH metry which is positive. Along with this hiatus hernia, either there is esophagitis seen, or there is a Barrett's, or there is an early stricture developing, which are endoscopic signs of definitive GERD. On the other hand, just a hiatus hernia with no esophagitis, no stricture, no Barrett's, I would do a pH test of PPI therapy. If it is positive, The patient has got lot of symptoms, I would send them for surgery.
Okay, let's the second question then before we ask the second question, we'll come to more questions from
So this is
Dr.
a
Vivek.
patient with functional heartburn. Now, y'all think of the definitions. Functional heartburn is someone who did not have reflux. Now, this is a patient with functional heartburn who continues to have symptoms. So your first choice is stop medications, repeat pH study, off therapy. The second one is go to tricyclic antidepressants and reassess. Advise about lifestyle modifications or go for surgery. So can we go to the next? We can discuss questions while the...
Yes. While the answers come in. Okay,
Yes.
Shobna, I
Yes.
think Dr. Rajendra from Mangalore wants to know, and as does Dr. Hansa Shai from Gurgaon, regarding when to do off PPI pH metry and when to do on PPI pH metry in refractory patients.
So again, we'll go back that there are patients where you have not proven reflux. The patient has come to you with acid symptoms. You've given him a PPI. Endoscopy is normal. So you have no proof that this patient has reflux. You have symptomatic feeling that this patient has reflux. And then you have no proof that this patient has reflux. Then in that case, you stop the PPI at least for 2 weeks and do a pH metry. If you had proof that this patient has reflux, then in that case, you would do, then in that case, you have proof that means the patient had grade B or more esophagitis. You found that there was either Barrett or there was some other proof. Then in that case, or the patient has a previous study where a pH metry was positive. Now you think that this patient is not responding to your PPI. It is better to do a pH impedance on PPI therapy. Is that clear, Hansa? Maybe she can answer on the chat. Yes.
So we have a response to your second question.
Yes.
That, how to treat functional heartburn, and your message went very well. 84% said that they would recommend a TCAs.
Yes. I think that is an important message. I'm very happy that 154 people have actually given responses to the poll. Yes, I'm very happy that 0% said surgery. So surgeons in the audience may not be very happy, but that's fine.
No. Patients need to be happy, not the doctors.
Yes.
Okay. Right. I think coming back to these questions, I think you already answered that in part, that when you do off PPI pH metry,
yes.
2 weeks people should wait. That was Dr. Anand Ashish Chand's question from Delhi. How much time should be before pH metry should PPI be stopped? And you're saying 2 weeks?
Yes, 2 weeks is 2 weeks is usually ideal. PPI usually the effect goes on for about 8 to 10 days, but it's better to wait for 2 weeks.
Right.
Especially in these doubtful cases, if you wait for 5-6 days and you've got a negative study, you don't know what you're dealing with.
Okay. I think this is a question related to the 2 or 3 participants who want to know about this. Use of baclofen in reflux disease, particularly with low esophageal, low LES pressure. So should it be used? If so, in what dose and for what duration would you suggest baclofen?
So baclofen is not to be used when the LES pressure is low, because actually, there wasn't any time for pathophysiology of GERD to be discussed. So when the LES pressure is normal, it's in those patients that the LESRs are really important mechanisms of reflux. And you give the baclofen twice or thrice a day. In some patients, I've used it up to 3 or 4 months, and they've done very well.
Okay. So this is an interesting question from Dr. Dattatreya in Mumbai regarding the role of leaky tight junctions in esophagitis in refractory reflux. Does it have a role? And if so, then proteins like E-cadherin, that may be breakdown products, are they of use in diagnosis in reflux disease?
Well, that will be a little, we'll have to go into molecular biology for that. Yes, e-cadherin things have been done, and I haven't discussed that aspect today because it was really, going to be a very long lecture. So biopsies and sending them on for IHC will be useful only in a very small subset of people.
Okay, right. Another similar related but interesting questions again. Dr. Kiran Joshi from Mangalore and Dr. G.K. Pati from Cuttack want to know about any role for breathing exercises in refractory reflux disease, something like a diaphragmatic respiratory maneuver. Can it help in preventing reflux?
Diaphragmatic breathing doesn't prevent reflux. No. What it does is in patients with the functional heartburns and patients with reflux sensitivity, because there is a lot of visceral hypersensitivity in these people. In those people, diaphragmatic breathing will help. And we all know that an increase in stress does increase reflux symptoms. And these are people in whom we can help them because their perception changes.
But it's unlikely to be in refractory reflux where you expect a fairly
No,
severe
no.
disease.
If you have, so we had two types of refractory reflux. One where the symptoms were refractory and one where the GERD was genuinely refractory. In the second one, I don't think diaphragmatic breathing will help so much that the symptoms go away. In the first one, where it's only perceptive symptoms which are abnormal, yes, they are the ones who will respond.
Right. Dr. Tayu Manavan from Chennai wants to know about bile reflux. That happens, does it produce symptoms similar to acid reflux?
Yes.
And if so, how would you treat alkaline reflux or bile reflux?
So, bile reflux, previously we had these probes called Bilitech, which were being used. And this bile reflux has again come up in the last 2 years when people are trying bile acid binders. So you can try cholestyramine, and some of these people do respond. And the way to diagnose now, there's no longer any pHmetry available. So radioisotope studies have been tried, where you can do a HIDA and look at the esophagus and the stomach window and see whether the bile is actually coming up into the esophagus. That's one of the ways in which people are diagnosing that.
No, the symptoms will be the same and the treatment?
Almost similar. The treatment is bile acid binders. And PPIs are not going to affect these patients much. In fact, they may worsen the symptoms.
Right. Dr. Sajid from Kochi wants to know about, have you seen patients with celiac disease presenting with reflux or as reflux disease?
My experience with celiac isn't much because we don't see that much in Bombay. But maybe I can ask Govind that. He has a bigger experience with celiac disease.
Not really, because see that we have patients with celiac who have heartburn, but again, no, celiac, yeah, GERD is so common, 15% of population, so both may coexist together. So you also we should know that celiac disease may remain totally asymptomatic because the spectrum of manifestation is quite wide. Some may totally from asymptomatic stage to severe symptomatic state. But I'm not sure there's any correlation between two conditions. Certainly there are studies that celiacs do have a high prevalence of esophageal esophagitis and lymphocytic esophagitis, but association is still not confirmed.
Right.
Okay.
Dr. Arun Bhadoria from Lucknow wants to know about role of PSPW and MNBI in the diagnosis of reflux. I hope those acronyms make sense to you, Shobna.
I hate acronyms. MNBI is mean nocturnal basal impedance, which we discussed. And it is, again, like I said, so these additional things are only useful when your basic pH impedance study is normal. You taken the patient on, say you've done the the study on PPI, the number of reflux episodes on that was less than 40. And the pHmetry wasn't very helpful. Then you start adding on these things and see whether it really helps. So if the MNBI is elevated, you think that probably there is some mucosal irregularity. Basically, whenever, sorry, not elevated, whenever the MNBI is elevated, It means that there is actually air trapping between a slightly esophageal irregular mucosa. And that is when the MNBI gets elevated. And therefore, it's abnormal. As far as PSPW is concerned, it does not diagnose reflux. No. It tells you that there is a good peristaltic reserve and there is a good secondary peristalsis which comes up immediately after a reflux episode.
Right. Thank you. Okay. Dr. G.K. Pati from Cuttack wants to know about the role of rebamipide in GERD with erosions.
So rebapamide is a drug which is basically a mucosal agent. But from what I know, it is better for the stomach. I have never used it for reflux. It's good for gastritis. It's good for dyspepsia. But I have never used it for reflux, and I don't think it will work there.
Okay.
Sucralfate might get stuck there, but I don't think rebapamide does.
Rebamipide will. Okay. All right. So Dr. Robert from Thrissur wants to know about sustained release PPI preparations for reflux. What is the place for sustained release PPI preparations?
No, I don't think there is much of a role for sustained release. And the reason for that is the action is somehow not as good as non-sustained release or the regular PPIs. So there is this study about 7-8 years ago published in Alimentary Pharmacology Therapeutics, where these Japanese investigators had done rabeprazole 80 milligrams once a day versus 20 milligrams 4 times a day. And they found that acid control was much better with 20 milligrams 4 times a day as compared to 80 milligrams once a day. So even within the PPIs, if you give them the regular sustained release are available, what we call them as OD drugs. They are not as useful because acid is going to be secreted every time you eat, and the proton pumps are going to be regenerated regularly.
Okay, right. So similarly, I think you mentioned that you must take PPI fasting,
Yes.
empty stomach, and after that, then you need to take meals after a certain period of time. So Dr. Dattatreya's question is that I think there are some people, it is being projected by some pharma people that rabeprazole does not need to be taken empty stomach. It can be taken at any other time. So what is your take on that?
No, rabeprazole has to be taken with the meal. The one which you can ignore the meal timing is the dexlansoprazole as well as the vonoprazan. That doesn't matter. Vonoprazan, of course, is not a PPI, it's a PCAP. So then it doesn't really depend on the absorption.
Right. Okay. I think many people have this question that Dr. Virendra from Bangalore is one of them. Others' names I don't have them handy here. About the duration of PPI therapy in people whose symptoms do respond. How long should PPI be continued? And then again, similar questions are related. Dr. Vimal from Rajkot wants to know about the long-term side effects of PPI that you might have encountered in patients who are taking it for a long period of time. Linked questions.
Yeah, so first is patients who respond initially in the first 1 month, they have had mild reflux. Many of them will not require PPIs long term. So you can stop them at 1 or 2 months. Taper them is possible because we know that there can be rebound acid secretion with PPI in patients who have grade C or D esophagitis. In them, PPI has to be continued long term. And in a lot of them, at the end of 5 to 6 months, you'll find that their symptoms are slowly coming back because though the acid is controlled, their perceptive symptoms are coming back. And then you've got to give them additional agents, mainly the drugs which are for perceptive symptoms like TCAs. On the other hand, you're talking about long-term PPIs, side effects. So in my entire practice of whatever number of years you can see, I have seen 2 patients with renal disorders. In one of them, temporarily, we could prove that it was due to the PPI. So this patient had a very large hiatal hernia and reflux. He took PPIs, his creat slowly started going up. After surgery, he stopped his PPI, create came down. He had some complication after fundoplication. We put him back on PPIs, and again his creat started going up. We had to eventually put him only on ranitidine. So there's only one proven case. There's another case where I have a slight increase in creatinine, but that we couldn't really prove it was due to the PPI. So in all the literature that we find, there are so many side effects that have been reported. I mean, the literature is overburdened with side effects of PPI. The only one where the relative risk is more than 3 is for renal disease. The other thing that we have to be careful is patients who have hypomagnesemia. These are the patients who can have complications of a PPI. And I think the FDA had put up a black box warning that magnesium levels need to be measured in patients before you start them on PPI. We don't do it. We haven't found any complications so far. And here I think we can have a show of hands amongst our panelists at least as to how many PPI complications you all have seen.
None.
None.
Not really.
I get generally recurrent severe diarrhea on patients getting food poisoning. I always find that the diarrhea is much more florid and they are more susceptible to food poisoning. The family members get a mild diarrhea, but a person on PPI get a really severe diarrhea when they get food poisoning. That's one thing which I have noticed.
So that is because of the flora having changed. Of course, there's also a higher incidence of Clostridium difficile, patients with SBP, in all that. And now, of course, there's within COVID, I think people are finding more on PPIs. And surprisingly, famotidine was found to be one of the successful treatments for COVID. So those are all flip-flop kind of statements that are coming up. But yes, diarrhea has been reported. But then I didn't put that as a long-term side effect of PPI. Because those are the ones that people are talking about. One of the thing is enteric infections, but yes, those are the only ones.
Dr. Varghese, you have any questions now? I think we have had a long 15-20 minutes.
We have too many. We have 168 questions. I think it will be impossible, humanly impossible, to finish all this in our limited session. And I think as per the protocol, these questions will be sent to Professor Shobana, and then the answers will be given, and Professor Makaria will take care that these answers are posted. I think that's the protocol I find.
Yes.
One interesting question was asked by Dr. Pradeep Agarwal about electrogastrography. Has it got any role in the management of refractory GERD?
So first point in this is electrogastrography is something that hasn't been standardized. Okay, so to prove gastroparesis, we need to actually do only a gastric emptying time. If the gastric emptying time is slow, then these are the people who will continue to have volume reflux even after, say, 3 or 4 hours after the meal. Whereas patients who just have a hiatal hernia, normal gastric emptying, after about 2 hours, the stomach is empty, they don't get volume reflux. So that is why we are, EGG is not much value here.
Another interesting question was about yoga therapy. Yoga, has it got any role in the management of GERD?
You know, if you want more patients, tell them to do Sirsasana. They'll come back with more symptoms. But yes, yoga, we discussed diaphragmatic breathing. And diaphragmatic breathing is useful for decreasing the stress, but does not do anything to the reflux. The only piece of warning we have to give to the patient is never exercise after a meal. That means the patient always has to be empty stomach. 2, avoid bending exercises after a meal. Avoid doing abdominal crunches after a meal. Avoid wearing tight belts after a meal. So these are things which will help. But by itself, yoga will only decrease the stress and not do anything to the reflux disease.
Dr. Sunil from Trivandrum has made a comment that the gastric probe was not seen in your slide. Is it not mandatory to have a gastric probe as well as an esophageal probe when you do pH metry to avoid false?
Maybe I did not show it, but there was definitely a gastric probe there because you want to know what is the gastric pH. If the gastric pH is high, And the esophageal pH will always remain high because even if there is reflux, the pH is not going to drop. So there has to be a gastric pH. And here I can think of one interesting case that we had seen. The patient kept coming with heartburn, epigastric pain, heartburn, epigastric pain. We did a pH. We put a pH, and my technician told me that this patient has definitely taken a PPI in the morning because the gastric pH is 7. So we asked the patient, she said, no, I haven't taken any tablet. So we tried to do it a second time, again off PPI, again the gastric pH was more than 7. This patient had gastric atrophy.
Dr. Siddhartha was from Mumbai has asked, and many other people have also asked about non-PPA drugs regarding antacids, sucralfate, alginate, etc. So what is your take on these drugs for the use of GRD?
So in patients who have mild symptoms, antacids are good. Antacids give very good immediate relief. So also the H2RAs, immediate relief is very good. The other one is alginates we use whenever there is volume reflux and an acid pocket or a hiatal hernia. Now I did not discuss the baseline management because we jumped directly to refractory disorders, and therefore I really did not discuss the lifestyle management and all that because we presume that in patients who have refractory symptoms all this has already been done.
If you have more questions, otherwise we can conclude.
I think there are many questions, but I think probably it will have to be managed offline.
Okay.
Dr. Bhatia, I have a couple of questions which comes to mind that you talked in depth about functional heartburn and esophageal hypersensitivity. But suppose I have a patient who have a reflux disease, reflux symptoms, but I don't have access to manometry or pH metry. So what could I do in such situations when I don't have access to these advanced technology? And we know there's a reality in our country that only few centers in our country have access to these. So what else can we do? Do we have any clinical parameters that we can suspect and start TCAs, as you suggested? So would you suggest something on that?
So see, in real life also, even if my center has manometry, every patient does not go for that. So first, if a patient you are sure has reflux disease, like we said, continue PPIs and decide. If a patient does not have, maybe try weaning off the patient of the PPIs and see if the symptoms are changing. Quite a few times you will find patient will say, I feel the same as I was not taking, when with the PPI or without the PPI, my symptoms haven't changed much. Then you know that this patient probably has an additional visceral hypersensitivity and a functional component, and they can be added. Or a patient whom you know that the endoscopy was normal on the PPI continues to have symptoms, you can even add a drug, give them a TCA or an escitalopram or something anti-anxiety like a vildafaxine, and they do well.
Thank you so very much, Dr. Bhatia. In fact, the objective of this topic was that the GERD is very important disease for all of us, and but at the same time, there are certain patients who don't respond to usual PPI, and our focus on this talk was to fish out those issues and discuss in depth, which we don't often do in our usual conferences. Thank you very much, Dr. Bhatia, for bringing out those concepts of functional heartburn and visceral hypersensitivity. We are all sure that we will not able to diagnose these conditions very often without these tests, but again, certainly we can suspect and try keeping them off PPI and see that how do patients respond and add on TCAs. So we had a wonderful talk on difficult to treat GERD. Thank you so very much, Dr. Bhatia. Thank you so very much, Dr. Varghese, for moderating this session. Now, let me invite you to one other talk next week. This talk is again on important topic that is acute on chronic liver failure and newer concepts in pathophysiology and management. We know that we had a talk on ACLF a couple of weeks back by Dr. Saraswat, but again we believe that this topic is rapidly changing, and we have a renowned speaker, Dr. Rajiv Jalan. I think all of us know Dr. Rajiv Jalan is a professor at University College of London, and he's the main person or architect of the whole concept of ACLF and the mortality related to ACLF and near concept. So Dr. Jalan has agreed to speak to us on next Sunday. So next Sunday, 12 to 1, we will have a talk on newer concepts in pathophysiology and management of acute and chronic liver failure. Till then, we can log off, and thank you very much, everyone, for supporting this activity of ISG. Thank you, Dr. Bhatia. Thank you, Dr. Verghese. Thank you, Dr. Saraswat. Thank you, Dinesh, and thank you, Yogita. We also want to thank the Dr. Reddy's Lab, who support the ISG Masterclass as a academic partner. Thank you very much, everyone, and we can log off now and see you next week with another masterclass.
Thank you.
Okay, bye-bye.
Have a nice Sunday.
Have a
Thank
nice
you.
day.
Have a
Thank
good
you.
lunch.
Bye
Thank
bye.
you.
See
Bye.
everyone.
Bye, everyone.
Everybody enjoy the rest of your Sunday. See
Yes.
you next
Bye.
week.
Bye.
Bye.